So next up we have Professor Tiarnan Keenan from the National Institutes of Health. He's going to talk to us today about AMD, A Tale of Two Stages. So thanks, Tiarnan.
Yeah, thank you so much. Yeah, thank you to the organizers. It's a great privilege to be here and be able to speak to you. So yeah, I'm a clinician scientist at the National Institute, and one of my major research and clinical interests is macular degeneration. So I think my role is to follow on from Dr. Chakravarti and to continue, hopefully, to provide a high-level clinical perspective overview of AMD and hopefully set up the scene for some of the subsequent talks. So let's see, I have no conflicts of interest to disclose. And I've just got a kind of general background slide here with a few statements. We've covered some of this already. We can think of AMD as a slowly progressive degenerative disease of aging. So in that respect, perhaps it has a lot of common with other neurodegenerative diseases of aging, like Alzheimer's, dementia. Of course, in this case, the pathology is principally, but not completely exclusively, at the macula. So being, of course, the central part of the retina responsible for our high acuity vision. And we'll dive into pathogenesis later on in subsequent talks, but at a high level, maybe we can think of AMD arising through a kind of complex interplay between age, genetics, and environment. And in that respect, how do we think about age? Perhaps we can think about it as the kind of cumulative exposure of the tissue to these genetic and environmental insults over time. So we'll talk about smoking and diet, and I think I'll probably no need to emphasize to this audience what an important cause of visual loss AMD is, definitely in industrialized countries, but also with changing demographics around the world, also globally. And this is a kind of framework that I'll return to during the talk. Just quite a simplified high-level view of how we can think about AMD progression through the various stages and subtypes, going from the left to the right, from more mild to more severe, that Dr. Chakravarti has already, covered. But as she was alluding to, I'm going to focus a little bit more on geographic atrophy than neovascular AMD because, there's a sense in which we can think of geographic atrophy as perhaps representing the final common pathway of AMD progression. This kind of idea that, if all of us lived long enough to, let's say, 200 or so, all of us would, eventually have AMD and geographic atrophy. And neovascular AMD is perhaps a little different. Maybe we can think of it as a kind of partially stochastic offshoot from this, final common pathway, which is going more in this kind of direction. And the kind of subtitle of my talk was A Tale of Two Stages, and what I'm meaning by that is focusing on geographic atrophy, but thinking about these two stages here. Firstly, the long period of time it takes to get to geographic atrophy. So in true AMD, we shouldn't really see geographic atrophy before the age of at least 70 or so. So it takes kind of 7+ decades to get to this point. But by contrast, we know when there's a small focus of GA in the eye, then pretty much more or less there's going to be inevitable expansion of that atrophy across the macula. And we call it slow progression, but really it's much faster. It's going to take something in order of about 1 decade to spread to occupy most of the macula. So it's kind of like 7+ decades to get here, and then an additional decade. And I've got a few images from one of the patients from our clinic with geographic atrophy. Already, a pretty decent size at this point, and center involving. But if we kind of re-image these patients over time, we see the same patient here over the course of about 2 or 3 years, and we see this kind of expansion, a bit like a domino effect or like a brush fire, where we have the the leading edge, the perimeter of the GA, is just kind of expanding relentlessly over time, and with progressive loss of RPE cells certainly, and also photoreceptors and choriocapillaris. But interestingly, for any given eye, this rate of expansion over time tends to be fairly constant and linear. For most of the life cycle GA until you start to run out of macula and it slows down, but fairly constant. And by contrast, between different individuals, there's a great deal of variation in the rate of expansion for reasons we're only really just beginning to understand. So I'll return to those concepts, but that's what I mean by a kind of a tale of two stages, getting to the point of GA and then subsequent GA expansion. So, yeah, the organizers asked if I would, cover a couple of things in particular, following on from Dr. Chakravarti. So number one was to say a few more words about AMD risk factors, and including genetics, which we were starting to hear about a moment ago. But really just a fairly high-level kind of overview, more of a clinical perspective that should hopefully set up, the scene for later talks that go into more detail and omics. And then secondly, to say a few words about the ARED studies, AREDS 1 and 2 that led to the AREDS 2 formulation that's widely used these days, but also permitted a lot of additional analyses that Dr. Chakravarti was starting to mention. And then thirdly, to just delve into a few recent areas of interest, particularly diet and nutrition. So this is number one. I was going to dive into the risk factors. I've just got one slide on aging, a meta-analysis of a lot of epidemiological studies. So we see here the results of that meta-analysis. We're looking at the prevalence of late AMD by age, and the prevalence is on a logarithmic scale. So we see a straight line, so we can say that the prevalence of late AMD increases in a way that's genuinely exponential with age, with some very impressive figures as we get into later decades. And that's just late AMD. The numbers for any AMD, of course, are going to be much, much, much greater. I think a big meta-analysis of European studies showed that by the time you get to 75, as many as 25%, so 1 in 4 people aged 75 and older will have at least some degree of AMD. And those numbers are probably increasing. So that's as much as I'll say about age, and then I've got a few slides on genetics, but really, as I say, this is just a high-level overview. I think probably most people are familiar with the story from the early 2000s when genetic technology was really getting going, and it became clear that there were 2 loci in particular that were really strongly associated with the risk of late AMD. The first on chromosome 1 and the second on chromosome 10. The story has evolved since then. I guess it's 20 years ago now. I think we have an improved understanding, but still not perfect, of what's going on at the complement factor H and CFHR-related loci. The chromosome 10 story has been a more difficult nut to crack, and so there's still a lot of complexity there. But following on from those initial discoveries, people started to work together. In particular, the work of the International AMD Genomics Consortium pooled many thousands of patients and controls, and then you can do very highly powered genome-wide association studies. And there's a well-known GWAS. Some of the numbers I've included here, published in 2016, the Fritsch et al. One, which is still, I think, a really important reference point, even though we've probably done some refinement since then. So these very large GWAS studies still certainly, confirmed those 2 original loci at 1 and 10 that we can see there, but also, led to the discovery of multiple additional variants and loci. So as you see some of the numbers here, about 34 loci across the genome. I think they're listed in tabular form here. Obviously, this is really small, but that paper has all of the odds ratios and p-values for these risk and protective variants. And maybe just to return to a second to those 2 original loci, because I think they still remain a really dominant, feature of AMD susceptibility. And the kind of obvious reason why that's the case is that in both cases, you have this really powerful combination of both very high frequency in the population and pretty impressive odds ratios per risk variant. And so, I'm not dealing here with very rare but very highly penetrant, really genuinely disease-causing variants, like, for example, at CFH or CFI, at the population level, because of this combination of frequency and pretty impressive risk, these are the ones that have the highest kind of attributable fraction. And even at CFH, CFHR, there's a good degree of complexity. So you've got the CFH gene, but neighboring it, presumably because of previous gene duplications, you've got 5 related genes, and there are complex splice variants, with various permutations shown on the slide, and quite a lot of linkage disequilibrium. So, even there's complexity. It's probably best considered at the level of different haplotypes. So most of the common risk haplotypes all have this well-known Y482H polymorphism. So there's some idea that perhaps at the biochemical level, this is the variant causing the disease risk. There are neutral haplotypes. There are also quite prominent protective haplotypes. So there's a well-known one with the CFHR3-1 deletion and another I62V that I'm not going to go into. But a lot of subsequent biochemistry work has helped to some degree, for our understanding of how that leads to disease. But as I say, it's been even more complex. At the chromosome 10 story, we've got these two neighboring genes, ARMS2, HTRA1, and there again, there's very, very high linkage disequilibrium. So there's, using conventional genetic statistics, it's not easily possible to say which is the gene and which is the causal variant. And I guess some people are more in the ARMS2 camp, others in the HTRA camp, citing various biochemical evidence. But to return to the GWAS, it's more than just those two loci. As I said, we have those 34 and a few additional ones since then. So obviously, if we're trying to understand pathogenesis, we can try and see what clues that gives us. And it's not just CFH. We saw multiple other risk and protective variants at other complement-related genes. So that's clearly a really, defining aspect of AMD pathogenesis, that part of the innate immune system. But we see clearly, clustering of risk and protective variants in other pathways. And I think most of them have a very clear biological plausibility. So lipid transport, definitely, which makes sense if we think about drusen and outer retinal transport. ECM remodeling, which also makes sense if we think about Brooks membrane as a really key extracellular matrix, just that thin matrix separating the chaos of the choroid from the very tightly regulated anatomy of the retina, which is crucial to prevent the kind of ingrowth of neovascular membranes that Dr. Chakravarti was mentioning. And for similar reasons, angiogenesis, that makes sense as well if we think about neovascular AMD. And so we can do various things, particularly if we want to start doing genotype-phenotype correlations. We can take those GWAS results, we can calculate a weighted polygenic risk score for any individual to calculate that person's genetic load of AMD. And even more kind of refined way, we can do pathway-based and polygenic risk scores to try and see what's the contribution in any one individual for these different aspects of the pathophysiology. So I think that's probably as much as I'm going to say about genetics as well. As I say, it's just to set up the scene, for subsequent talks. And I've got a couple of brief slides on some environmental risk factors. We can do kind of similar things. We can pool epidemiology studies by meta-analysis to try and get the most highly powered idea of what risk factors are important. And I think this paper that I'm quoting is actually from Dr. Chakravarti from a few years back. We're not considering diet and nutrition here. That's almost so complex we have to consider it separately. But essentially, from a large pool of potential risk factors, pretty much always the one that comes out on top is smoking. So smoking pretty much doubles the risk of late AMD. There are others that are fairly consistent but have a kind of more moderate level of increased risk, and they're things like hypertension, cardiovascular disease. So it's a different picture from heart disease, for example, where it's definitely smoking, but it's also diabetes, hypertension. Smoking for AMD is certainly important, but the others, hypertension, diabetes, are only fairly modestly important. So again, maybe giving us some clues to the partially distinct pathogenesis. I think Dr. Chakravarti's already talked a little bit about management. I'm not going to go into this in any detail. I'll just say very briefly that for early AMD, the mainstay of management is lifestyle modification, particularly diet, smoking cessation. For intermediate AMD, where things are a little more advanced, it's again lifestyle modification, but also now AREDS2 supplements and more intensive monitoring. And then we've already heard about neovascular AMD, mainstay of management being anti-VEGF therapy, and geographic atrophy, not a great deal we can do to slow that expansion rate, although we do have the first two FDA-approved drugs that come with their kind of limitations. Okay, so that's pretty much the first point covered, and then the second thing that the organizers asked if I might be able to do is to say a few words about the AREDS studies. Leading to the approval of the specific formulation of supplements, but also giving us a lot of data for all kinds of analyses. So, and some of these slides are from Dr. Chu, who, as you probably know, is responsible for a great deal of this work in AREDS1 and AREDS2, and there's a kind of summary timeline of a lot of that work. And so from my understanding, things started in the late 80s or early 90s, across the field in many domains. There was a lot of interest in whether antioxidant oral supplements might be effective in everything, cardiovascular disease, cancer, etc. But AMD was really one of the only success stories in that area. But it led to the AREDS, the Age-Related Eye Diseases study, looking at AMD, actually not just AMD, but also cataract, where they were not successful. But the idea was to recruit a large number, about 4,000 people, randomize people to oral supplements or placebo, and follow them by a randomized trial for about 5 years, and see, and it turned out they were effective in decreasing the risk of going on to develop late AMD, followed by an epidemiological follow-up period. But, I guess one's always trying to improve things, so then the idea rapidly followed on for ARIDS-2 study. Can we improve the formulation? So again, people with AMD were recruited. They were all now going to get the ARIDS-1 supplement, but they were randomized to some additional supplements as well. And that RCT period lasted for about 5 years and was also followed up by an epidemiological follow-up period. So that's just a kind of brief view of it in a nutshell. But then to return to the beginning, this was ARIDS-1. So as I say, about kind of 3,500 to 4,000 people were recruited with a whole range of AMD, from like very mild to moderately advanced. And this was the well-known randomization. So people either received oral supplements with really high-dose antioxidants, so that was vitamin C, vitamin E, and beta-carotene in combination, or to high-dose zinc, about 80 milligrams. And I still think we don't really know for sure why that seems to be effective. It certainly interacts with the complement system, so that's one possibility. And then in this 2x2 design, a quarter of people get the combination and a quarter of people just get placebo. And then they're followed for 5 years with repeated imaging and testing. And then over that time, you see, do people progress to advanced AMD, people who didn't have it at baseline. And this is one of the kind of headline slides. Essentially, the people who did worst were the people in the placebo arm. So here's their pretty high rate of progression to advanced AMD. And then all of the 3 active treatment arms did better, but the ones who did best of all, it's shown in blue here, are the ones on that combination treatment, both the antioxidants and zinc. And so, if you do the statistics, it turned out that people on that combination compared to people on placebo, their rate of going on to advanced AMD was decreased by about 25%. So it's not 100%, it doesn't stop AMD. I think not everyone is always aware that this number, this effectiveness, is driven mostly by greatly decreased risk of going on to develop wet AMD, and sadly not really any decreased risk in developing geographic atrophy. So that's worth bearing in mind in those post-hoc analyses. But broadly speaking, at least this was a big success story. At least this is something that decreases the risk of late AMD and neovascular disease in particular, and became the kind of standard of care from that point onwards. And it was recommended for people in these particular categories. So not everyone, not the general population, not the kind of necessarily children of people who have AMD. One other important part that came out of it was problematic. From this trial and from some other trials, it turned out that the beta-carotene, part of the antioxidant supplement in particular, was increasing the rate of lung cancer, it seemed, in people with a smoking history. So it was definitely not recommended for people with a smoking history. And that was another aspect of ARIDS-2 to try and address that safety problem. And another part of ARIDS-2 is data from ARIDS-1, and also other studies had started to suggest that it's quite important, what you eat for developing advanced AMD. And in particular, it seemed that people eating these kind of green leafy vegetables that contain a lot of lutein zeaxanthin, these important carotenoids that are really highly concentrated in the macula, so presumably, are doing something important there. But we can get only from the diet. We can't synthesize, de novo in the body. They seem to be doing well, relatively protected from late AMD. And also, it turned out that people who were eating fish seemed to be quite protected from late AMD, and was even suggested to, explain some of the differences in different geographical areas where some people have very low rates of geographic atrophy despite a high genetic load. So the idea was, can we take these and put them in a pill, basically? And so ARIDS-2, sought to address these two things: the safety concern of beta-carotene, and also can we improve on the formulation with either lutein zeaxanthin, or can we distill fish into this fish oil, these omega-3 PUFAs, DHA and EPA. But to get into ARIDS-2, you had to have a bit more advanced disease than in ARIDS-1, at least intermediate AMD, or advanced disease in one eye but not yet the other. And as I say, ARIDS-1 was now the standard of care. So everyone was going to get those antioxidants and the zinc, but now we can randomize people to these two additional components to see if they're effective: the lutein zeaxanthin or the omega-3 PUFAs. or the combination or placebo. Again, of course, we need that comparison. So to cut a long story short, the omega-3 fatty acids, disappointingly, were not at all effective in decreasing the rate of progression to late AMD. But by contrast, at least the lutein zeaxanthin, they were effective in decreasing the rates of progression. There are more nuances and details we can get into if it's helpful. But the other thing was that, in kind of secondary analysis of a head-to-head of the beta-carotene that had the safety problem against the lutein zeaxanthin that did not have any of those safety problems, it turned out lutein zeaxanthin was more effective. So both on the grounds of safety and on the grounds of improved efficacy, essentially the idea was to drop the beta-carotene, but now we can replace it with the lutein zeaxanthin. The effectiveness should be improved and the safety problem is eliminated. So pretty much this is the final ARIDS2 formulation that's been very widely marketed and taken in many countries since then. We've still got the antioxidants from ARIDS1, lutein zeaxanthin is added, we've still got the high-dose zinc from ARIDS1, and the copper is just occasionally, if you give high-dose zinc over a long period, it can induce copper-related copper deficiency anemia. So the copper is just to address that potential deficiency. And just to sum that up now diagrammatically, the ARIDS2 formulation supplements are indicated for people they have to have at least a degree, intermediate disease, and they're really good at decreasing the risk of neovascular AMD, but sadly they don't appear to decrease the risk of geographic atrophy. So they have, an important role, but a relatively limited role. Okay, so I hope that's useful as a high-level summary. In questions to any of that it's helpful to return to, I can do that. And then finally, in the kind of last, 10, 11 minutes, I can delve into a couple of these things. The reticular pseudodrusen or subretinal drusenoid deposits have come up already. I can show some data relating to that, but still a really active area of interest. And diet and nutrition, which of course is related to oral supplements, but they have their differences. And so this is just to return to that concept that I was mentioning at the beginning, a tale of two stages. So I tried to synthesize a couple of years back some research from our analyses in ARIDS 1 and 2 and from other groups as well to think about these two stages. We'd had a lot of research, risk factors to getting to late AMD, particularly geographic atrophy, and there'd been much less research at the second stage for geographic atrophy expansion. And this is too small to be read in detail. It's just to show the structure. Essentially, I wanted to look at the risk and protective factors for that first stage, getting to the point of GA. And so those are shown on the left here, but also to try and fill in some gaps. What are the risk and protective factors for the second stage? We see this difference in GA expansion rates between people, and can we start to explain some of that? But I think what emerged from that is that some people assume that the risk factors are really uniform across the whole AMD severity spectrum. And actually, I think that's not the case. And of course, that's important for this kind of audience because I think the mechanisms driving AMD progression are actually quite variable according to these different stages. So maybe the mechanisms driving GA expansion are actually quite different to the mechanisms setting up the macula for GA occurring in the first place. And then, of course, that's important because the therapies probably need to be stage-specific, possibly even genotype specific, but that's probably more contentious. Because certainly, at least in my analysis, there are some shared risk factors for GA occurring and for GA spreading more quickly. So smoking would be a good example of that. In the ARIDS 1 and 2, it definitely increases the risk of GA occurring, and it's also associated with faster GA expansion. But on the genetic side, for example, it's a really different story. There's been a little less work done on the genetics of GA expansion, but now we and others have done genome-wide association studies. Actually, the only genetic point of overlap in terms of risk factors between these two stages is at ARMS2-HTRA1. So the risk variants there definitely increase your risk of GA, and they kind of modestly are associated with faster GA expansion. But aside from that, the genetics of these two are almost completely non-overlapping. Definitely all of the CFH, CFHR variants and haplotypes are not at all associated with slower or faster GA expansion. I think that's an important message that's not widely understood. Might even call into question whether it was biologically rational to think about complement inhibitors for this stage, and may explain why their efficacy is not as much as some had hoped. And actually, there are very few genetic hits at genome-wide significance despite high power. So I think GA expansion is, there's something different going on. And diet, we can talk about. Diet seems to be, helpful at both stages, but actually perhaps for different reasons, and I'll come to that in a moment. Okay, so so maybe I can just say a few words about reticular pseudodrusen, also known, as we heard, as subretinal drusenoid deposits, because as Dr. Chakravarti was mentioning, we don't usually see these deposits clinically or on traditional imaging. We need, fundus autofluorescence or OCT to be able to pick them up, and that's why they weren't in the original severity classifications and risk calculators. And so when I'm saying third here, I mean, the first would be drusen, the second would be pigmentary abnormalities, and so the question arose, are RPD an additional risk feature? And I think, again, for this audience, the mechanisms there are going to be important. I think, like Dr. Chakravarti was saying, it was difficult because if you have RPD very often, but not always, but very often they coincide with the other features. So you really need large data sets with every combination of drusen size, pigmentary abnormalities, and RPD presence or absence to try and dissect the risk associated with each one. But you do definitely see people, I don't know how well this projects, but this is an individual from our clinic who has two distinct populations of drusen. So in the temporal macula, we see the traditional soft drusen, these fluffy-edged, kind of confluent drusen, and we see them on the OCT here with that kind of gentler contour. But elsewhere, we see these punctate deposits in a kind of C-shaped distribution, and they're kind of in this kind of regular order, ribbon-like, as we heard. And so we really didn't know what this meant. Does this put someone at higher risk or not necessarily? And we see they have a kind of different anatomical characterization, potentially in a different retinal compartment. And to cut a long story short, we needed to use some AI work, training deep learning models to help us with grading of RPD, but I'm not going to go into. To cut a long story short, essentially we found that they were an important risk factor. They pretty much doubled the risk of progression to late AMD. So whatever you risk, you had from your traditional drusen and pigment, if additionally RPD were present, you could double your risk with a hazard ratio of 2. So that seems important, but I would say it's, that's quite modest in comparison to drusen, traditional drusen. So the equivalent hazard ratio for large drusen would be something like times 20 or times 30 risk, which seems much more, truly AMD defining. So I would say RPD are almost more kind of modulating risk. Although they do have these particular associations that we were hearing about, for example, with type 3 RAP lesions. But they appear to increase risk at all AMD severity levels. One interesting thing about them is that the other features, drusen and pigment, they tend to increase the risk of both subtypes roughly in parallel. At least in our analyses in AREDS 1 and 2, RPD are a bit different. They really disproportionately increase the risk of geographic atrophy. With some very high hazard ratios there. So there seems to be a strong relationship between RPD and geographic atrophy, and perhaps quite aggressive GA as well, quite multifocal and rapidly progressing GA. And I won't dwell on this too much, but more for a clinical audience, I used that to update the AREDS AMD simplified severity score that we were hearing about before. This was the traditional scale, which is great for giving a kind of not a very granular, but a great kind of relatively simple risk categorization for 5-year rates of progression to late AMD. But if we want to incorporate RPD alongside the two traditional risk features, this is the kind of thing that we get here. There's one scale for people with and one for people without RPD. And then, and just maybe the last few minutes, if we have time, I'll say a few words about diet and nutrition, which kind of follows on a little bit from the supplement story, but has its differences. But again, I was going to try and think about that in the same way, these two different stages. Firstly is, can diet be helpful in decreasing the risk of getting late AMD and GA in particular? And secondly, could it help us with GA expansion? And the kind of healthy eating pattern in particular we were looking at here was the Mediterranean pattern, which has attracted a great deal of interest for, cardiovascular disease, dementia, etc. But I think it's not specific to that. I think Mediterranean diet has a great deal in common with other healthy eating patterns like the anti-inflammatory diet or low glycemic index diet, predominantly plant-based diet. These are all much more similar to each other, by contrast to the modern Western diet. But obviously, when we're talking about Mediterranean diet, we mean an emphasis on fresh fruit and vegetables. More fish, less red meat. In terms of lipids, more olive oil, avocados, plant-based lipids, and less saturated fat. If we want to approach it scientifically, quantitatively, in particular, this was the very highly validated index developed from cardiovascular disease. We can characterize these 9 components and see if someone's diet is very kind of Mediterranean and healthy or not so much. And to cut a long story short, we did that in the ARIDS 1 and 2 studies. And of course, we have to bear in mind in the statistical models what randomization people are on. But when we do that, and when we include in the models all kinds of things that diet is associated with, of course, it's associated with smoking, etc. But we still find that a healthy diet is very strongly associated with slower progression to late AMD. So we're looking at tertile. This is kind of tertile 3, the third of people in the data sets who happen to have the more healthy diet. Tertile 2 is intermediate, and tertile 1 as reference is the third of people who happen to have the least healthy diets. And this is just observational, so that there's a caveat there. We're not randomizing people. We're not trying to change their diets, just taking their diet as it comes. But we do see a dose-response association suggesting diet is really important. And I think that goes along with what we've learned about cardiovascular disease, even dementia, perhaps cancer. One thing that's quite interesting, as I was saying earlier on, the supplements, these are very robust data by randomization. We know are great at decreasing the risk of neovascular AMD, but not at all, unfortunately, for geographic atrophy. But interestingly, it's a different story for healthy diet. Healthy diet is associated with decreased risk of both, but much more strongly with decreased risk of geographic atrophy. So I think that's at least perhaps some good news in a way, because we've got very little available to decrease the risk of GA, and it seems that diet is a really important part of that story. But for this audience, mechanistically, I think it's really interesting to think about why one is more weighted to one and one to the other. But clinically speaking, it's a really important message, because we need healthy diet and supplements in combination. They're complementary. It's not enough just to take a pill, to take the ARIDS 2 supplements and eat really badly. We need to decrease the risk of both subtypes, and so that's why supplements and diet are really important together. Another thing that's quite interesting is, for cardiovascular disease, this kind of approach was developed because a little bit of each of the components was important to get that overall effect. And if we statistically try and isolate each of the components to their, to the overall contribution here, it turns out that that's not quite the case in AMD. Some are moderately important, but there are some that stick out much more than others. And vegetables to an extent, but fish is the one that sticks out the most. And I think I was alluding to that earlier as the kind of justification for the omega-3 fatty acids in ARIDS 2. So it's a bit of a strange situation where we see observational data suggesting fish intake is really important. But then by randomization, these particular omega-3 fatty acids, EHA and DPA, were not effective. So is it something else about fish? But I think people are still very keen to know what's the situation there. Is they contain a lot of B vitamins, or is it, do you need the really ultra long chain fatty acids? I think, ideally we would get to the bottom of that and try and understand that discrepancy. I've not shown the data here, but healthy diet's also really important for decreasing the risk of AMD in the first place, and for progression to intermediate AMD, and definitely for decreased risk of GA. So it's important right across the board. And I'm going to skip over this. There's also, a lot of analyses you can do at the level of individual micronutrients. So we have all these kind of protective associations and some harmful associations with individual, vitamins, minerals, and lipids. So I think pretty much finishing up now, last few slides, but this is looking at diet at that second stage now. Could it be important in GA expansion? We had a very pessimistic view. We'd had many failed trials of drugs trying to slow the GA expansion rate. And people just seemed to have their constant rate. There wasn't anything you could do about it. But, I thought it was worth looking to see if diet might be related to try and, answer this question. And cutting a long story short, it turns out, and I think to many people's surprise, that people's rate of GA expansion seemed very strongly associated with their diets. So again, we're trying to adjust for as much as possible, smoking, etc. But there is a risk there might be some residual confounding. But it did appear there was a really strong association. People whose diets were healthier, more Mediterranean, had much slower GA expansion rates. And if this story is true, these rates are at least as high as some of the most successful trials of injections needing to be given in the eye every month. Another facet of that is quite interesting. You imagine if you did these same kind of component analyses, we might see the same thing. Vegetables and fish. We actually saw a very different pattern. Fish intake was not at all associated with altered rate of GA expansion. And the ones that stuck out the most were quite a different pattern. It was all about fruit and vegetable intake, suggesting the antioxidants perhaps are important, and less red meat intake was also really important. And these were actually very, very strongly associated with big effect sizes. So diet's important potentially even at this stage, right across the board. And if we superimpose that with supplements, they're complementary. Supplements have this very specific role at intermediate AMD onwards, whereas I think diet has a more broad role, and that's why both are important together. So some overlapping risk factors, but actually many, especially on the genetics, non-overlapping risk factors, telling us, I think, that the mechanisms for GA expansion are different to the mechanisms setting up the stage for GA occurring in the first place. Probably want to leave time for questions, so I might just skip through this, but we've talked about genetics, importance of diet and nutrition, and many unanswered questions, some, at least on the clinical side, that come up a lot. To what extent is AMD inevitable or avoidable? To what extent do we need to personalize treatment? And always, can we intervene earlier? But yeah, I think that's pretty much it. So thank you so much. A few references there, some reviews, and some ARES 1 and 2 publications at the top. But yeah, thanks for your attention.
Thank you. Here's one.
Hi, Tiarnan. Thank you.
Sorry.
Wow. So I had a question for the reticular drusenoid, and I have small multiple questions. So do reticular drusenoids are also very macular in location, or they can be in the periphery?
Good question. I'll answer that because otherwise I'll forget. So they have a partially overlapping but a partially distinct distribution. So the large drusen are mostly confined to the posterior pole, particularly the macula, and often clustered quite centrally, whereas RPD are found there, but they go a little bit more peripherally beyond the arcades. Okay. They have a bit of a characteristic distribution. They come above the optic nerve and then kind of wrap around. So there are nice percentage topographic maps by Robin Guyman and others. But yeah, a little bit wider distribution, probably telling us something important.
And do these drusenoids also remodel like the drusens, but they come and disappear and appear?
Yeah, they do have a life cycle. I'm not an expert in that, but there's some nice work on adaptive optics and other imaging. So they come, and then over a period of years, actually, they can resolve. I mean, there's a staging, stages 1 through 4, and 4 is really the point at which they've resolved. But when I say resolved, not necessarily in a good way, often with outer retinal degeneration accompanying it. So, I think there's probably lots of insights we could take from that life cycle, which we're only beginning to understand.
Thank you. Wait. When you're asking a question, please stand up and say your name, and then we'll go over there. Thank you.
Hossein Amiri, thank you for the wonderful talk. Is there any way to compare the effect of diet and supplement with the complement inhibitors that now they show the rate of progression to basically have an answer, how effective they are compared to the other one?
No, it's a good question. It's a difficult comparison to do because this dietary data is observational. So obviously, the highest grade of evidence would be by randomization. So it'd be great if we could randomize 1,000 people to different dietary interventions, but very, very difficult to do, especially over the long period required for GA expansion rates. So we've got great data from the clinical trials on these interventions that you have to give by injection, and as Dr. Chakravarti was mentioning, on structural outcomes, they appear to slow GA growth. There's some worry that the imaging modalities we use that may break down under the conditions when we give complement inhibitors. It's a complicated story, but there are no head-to-head comparisons. I will say, by observational data, the kind of data I was showing, people with healthier diets have slower rates of GA progression of a kind of similar degree that you'd get from the interventional trials, but it's not a particularly meaningful comparison. Yeah. So difficult answer, yeah.
So,
Hi.
Oh, sorry.
My name is Martin Paul Agbaga, University of Oklahoma. Really good talk. I like the title, Tale of Two Stages. I mean, one thing you have really made clear here is the role of diet in the whole progression process. But then, disappointingly, the ARES-2 study did not really attribute any changes to EPA-DHA. Right. But then, now looking back, I remember that talk in Seattle when Emily presented that data. Now, looking back now, almost a decade later, now we do know that there are a lot of changes in these lipid metabolism genes, and those NIPs can differentially affect how you elongate or desaturate these fatty acids. Are you able to go back to those data and then bring the genotype correlation and see how those NIPs could have contributed to that disappointing data?
That's a great question. And I really like your work on the ultra long chain, PUFAs. And there's this, in a kind of monogenic situation, we've got the unusual Stargardts giving us an indication that the elongation enzymes are really important. I don't know that those specific analyses have been done looking at, DHA and EPA. Could they have been effective, but only in people with particular genotype? It probably should be possible to do that. I guess there is always, some difficulty with post-hoc analyses like that, but I guess it should be possible to do that, and I don't think it's been done. Yeah, but yeah. Yeah, no, it's a great suggestion. Yeah, thank you.
Hey, how you going? My name's Nick from the Australian National University. I noticed that you showed but didn't really talk about the effects of physical activity as a modifiable risk factor for developing AMD. These studies are great at showing diet as a contributing factor to the progression of AMD, but in the ARED studies I noticed that they didn't really report levels of physical activity. My question for you is, do you think that more attention should be given to the effects of physical activity in the elderly where sedentary lifestyle is more inevitable? Do you think we will be effectively able to supplement the effects of physical exercise in addition to supplementing these things that are known to progress AMD? No,
it's a great point, and there's quite a simple reason that, unfortunately the ARES 1 and 2 studies didn't collect that data, so I'd love to be able to present that, but it just doesn't exist. But of course, it sounds very biologically plausible. I'm sure exercise and physical activity, is really important alongside diet, so that, as you say, lifestyle modification more generally is an important mainstay. I think we only have, there are some bits of data. Dr. Caroline Klaver is doing some really nice work doing, lifestyle interventions in a kind of small pilot randomized way, including, activity alongside diet. So I think that is a really important part of the answer. I think hopefully future studies, maybe we can incorporate accelerometers or, kind of wearable technology to acquire that data, which wasn't the case, back then when these studies were done.
Awesome, thank you.
Yeah, thanks.
Thank you for the fascinating talk. Nemanja Milicevic from Tampere University, Finland. I was fascinated with the recapitulation of the ARED study. I had no idea that the recommended zinc intake is 80 milligrams per day. I mean, we have to bear in mind that the recommended daily intake is 10 milligrams. So this is like completely overloading.
And it differs by country. I know in Europe there are kind of more modest recommended upper limits. Yeah.
So is there any reason why such a high dose is selected? I mean, I would perhaps we would see an even better improvement if we just lowered the dose, perhaps.
Well, I guess the high quality data comes from the randomization, so there's direct, safety data from 80 versus 0, and then I didn't go into it, but in AREDS 2, we, there was a secondary randomization to 80 versus 25, so there were no safety. Significant safety problems. But having said that, more recently, National Institute is thinking about suggesting a more modest amount of 25 because it's not quite as high quality data, but the efficacy of 80 versus 25 did not appear different.
Yes, and I have one more question.
But to address your question more directly, I think the reason was that was the rate, that was the dose people suggested at the time, and let's say if you have a small dose, the criticism afterwards is always going to be, it didn't work because you didn't give enough. I think that was the reason for 80, but it was long before my time.
Yes, and considering that what you have showed us regarding the effect of fish intake and decreased progression in AMD and the lack of effect when you supplement with omega-3 fatty acids. I was thinking, what do we know about the effect of mercury and AMD progression? It's a bit crazy idea.
Yeah, it's not an area that I've published on. I think there are some data out there that I don't know well. But yeah, I think there are also, across the other heavy metals as well, there's some data linking, intakes of different, cadmium, mercury, etc. But I'm not an expert on that. Yeah.
Tiarnan, Catherine Bose-Rickman, Duke University. That fabulous talk. You brushed in. You just put it on the slide really quickly, and I'd love if you take a minute. It may take longer, to touch on this difference in the clinical trials between if you have GA on the fovea or off.
Oh, yeah. Yeah. Yes, so there was way too much, but I've got a whole, slides on geographic atrophy being center involving, non-center involving. Yeah, and any particular, is it foveal sparing kind of thing that you're interested in?
So wasn't there some differences in even how the gather, like the initial ones, where they showed if you were on or off, you had a better response to the complement inhibition? Yeah,
and there's many facets to that. So we know that the rates of geographic expansion, are significantly different according to whether you have center involving GA versus non-center involving GA. So they're faster with non-central GA. And then, the different trials have different approaches. So the Derby and Oakes trials of pegcetacoplan, they took all comers, center and non-center involving. Gather-2 for avacincaptol were different. They took only non-center involving cases. And then, so I think in post-hoc analysis of the former, Derby and Oakes, the suggestion was that efficacy was higher. Which way around was it now? I think in the non-center involving.
And that was why the initial rates when they didn't take any of the central were higher in the other study. So, but any thoughts on?
Yeah. It's a difficult, I think what we do know is some really nice work using the AREDS1 dataset by Linus, Shen, and others have shown that the speed of geographic atrophy expansion is faster the further out you go in the macula and much slower the closer you get to the very center. And so that leads to this really important phenomenon of foveal sparing where, in the lucky kind of 2/3 of individuals where GA, when it comes, is non-central, it spares the center. It wraps around, like a horseshoe and then finally like a donut until very, very eventually it snuffs out the center. But if we could preserve people in these foveal sparing states, that would be great. And I have some data suggesting that maybe the AREDS2 supplements do that, which might make sense if you give lutein zeaxanthin, maybe it's helping ward off the geographic atrophy, but we need to test that in a new trial, which we're hoping to start next year. There's probably more to say there, but that's,
there's a huge problem with interpreting those two clinical trial data sets, partly because the expansion rates of geographic atrophy is so varied amongst individuals. So once you start to break them down into quartiles, you find that there are some patients just don't progress at all, their GA stays, their growth rate is so slow, and then you have the much faster growing ones. The faster growing ones are often the bigger ones that are located well away from the fovea. So there is a kind of and if you are trying to slow the growth of geographic atrophy and something is just not growing at all, you're not going to find a delta between any kind of groups. So you have a major issue there. So the faster growing ones, which are expanding possibly towards the periphery and possibly towards fovea, that quartile, you might find a difference. So naturally you will say, oh yes, there's an impact of the drug, because perhaps if you slow it down by 25%, you're seeing a difference. So unfortunately, they didn't adjust for all this. And they're tiny trials by, you're talking 200 to 300 patients in each arm. So if you want to split them into quartiles, that's going to be an issue. So it wasn't great.
Yeah, and in trial design, that's a whole thing.
Power calculation, sample size, and chance findings on randomized.
It's one interesting, some clinical trials have a run-in period for 6 months. Now, it's not widely adopted, but then you have the natural history of rate of growth, and then you can do covariate adjustment. But that's a great point.
Over here, Tiarnan.
Hi,
Oh, hi.
Thomas Heigl from Switzerland. Just very quickly, your professional opinion, and I want to go back to the exercise topic. And the background is me, myself, being diagnosed with RP, retinitis pigmentosa, because I realized when I, for example, hike up the mountains in Switzerland, also Austria, very quickly that it seems like I see worse for distinct interval. And I thought exercise, I think most of the people here connected to something healthy, but to what degree can exercise be maybe even worse for AMD patients? Because I think of like the short hypoxia in distinct tissues probably.
No, like you allude to, I think correctly, there are kind of short-term and long-term things. But I think there was some data, and again, it's not something on which I'm an expert, but suggesting that over the long term, exercise is beneficial. At the mechanistic level, maybe we can think about mitochondria. It's hard to think of a disease, especially kind of, slow disease of aging, in which exercise is not beneficial. So, but not excluding the fact there might be short-term difficulties, in particular oxygen conditions at altitude, I'm not sure, but long-term, I would think it's almost certainly beneficial.
Thanks.
Yeah.
Hey, Tiarnan.
Hey, Jason.
I think for biologists, looking at the genetics, it's really important, as you alluded to distinguish between gene prevalence multiplied by odds ratios to give us population attributable risk that tells us what do we care about for the overall disease. But if you're a biologist thinking about pathways, you even if it's an ultra rare mutation, the effect size is what we care about. Has anyone actually done just like the nice tables that exist, that you've put out on just the effect size of genes and sort of giving sort of the ignored population, amount of the genes, and give us a nice sense of maybe biological prioritization, from effect size highest to lowest?
I wish I had a specific reference or citation. I thought about including one of the nice charts where, you can plot the effect size, on the x-axis against the, the frequency in the population on the y-axis, and you see that kind of often, that curve, where CFH and ARMS2-HTRI1 stick out because they have both high frequency and relatively high risk. But then, of course, like you say, there are these, very rare but very, very highly penetrant, genuinely monogenic kind of disease-causing variants like at CFH, CFI. So I have seen those graphs, and I wish I knew which reference.
I feel like I haven't seen it across all. It would be of a high value.
They definitely exist.
Biological prioritization.
But
I've
no,
seen
as you say,
occasional genes, here and there, but not like the whole list.
No, I'm trying to think of which. Anyway, I'll try and
last question over here, and then you can read.
So thank you very much for a very interesting talk. Quick question. So if I remember correctly, the Mediterranean diet not only slowing down the GA progression, but also benefit for the visual function. I think this situation is quite different from complement inhibitors. So do you have any idea why this kind of difference happens between two treatments?
Between diet and complement risk?
Complement inhibitor only inhibits
complement inhibition.
GA progression, right? But they didn't show any visual benefit, right? BCVA benefit.
Oh, I see. Sorry, got it. And again, it's very difficult to make direct comparisons. But as Dr. Chakravarti was saying, in the Derby Oaks studies, for example, using the main structural outcome marker of like GA area, how that changes over time, there was efficacy according to randomization. But in all of the pre-specified visual outcome measures, visual acuity, reading speed, etc., there was no difference according to the randomization. And people speculate, is that because they didn't choose the right parameters, or were the inclusion criteria not quite right to show that kind of efficacy, or does it genuinely not show efficacy? We have to remember there are some eyes that did badly from complement inhibition, developed new wet macular degeneration caused by the injections, and their vision is going to be worse, so that will pull down the average. So it's a complex question. The diet, I didn't show the data there. I've got a paper in, I think, Nutrients last year, and there were significant differences with healthier diet according to, significant differences in visual acuity and so on. But those are observational, so there is a caveat. It's not by randomization. It's very difficult to compare. Yeah, thanks.
Okay, thank you very much, Tiarnan.
Thanks.
And thanks everyone for really great question session.